So we finished with the palpation of the pericardium and the sequence of palpation. Today we will discuss the second part of cardiovascular examination. Students, if you have any question in the previous lecture, I would be happy to post it in the form, and I'm going to answer all your questions for the previous lecture. So today we will discuss the second part of cardiovascular examination. Here are some questions to start refreshing your information. Where is the heart located in the chest, and what are the heart dimensions in an average adult? What are the systole and diastole? How do electrical impulses stimulate the heart muscle contract? Name 3 precordia sites recommended for auscultation of heart sounds. And which sound frequency is transmitted best by the bell of the stethoscope and the diaphragm of the stethoscope. Okay, so here we go to our lecture. As you have when you already know that the heart sounds that heard through the stethoscope during auscultation, are usually generated by vibrations of the heart wall, the heart walls and the valves. And so it is generated via the vibrations of these two structures, the walls of the heart, in addition to the valves, plus the turbulent blood flow. So these are the basic mechanisms why the heart produces sounds. Normally, the heart walls and valves are compliant as they move in response to pressure and volume changes during cardiac arrest. So they're compliant, they can expand and return to its normal size in response to the pressure. This is very important, two parameters, pressure and the volume changes during cardiac cycle. So during systole and diastole, the pressure will fluctuate in addition to the volume. The volume increases in, for example, in the atria, the volume increases during diastole, while in the ventricles, the volume of ventricles decrease during diastole and vice versa in systole. So this is the basic mechanism of heart sounds. It is vibration of the heart walls and valves, plus in addition to the turbulent blood flow. So the basic components of heart sound, the lub-dub sound usually, why it is produced by the closure of the atrioventricular valves, the valve that connect the atria to the ventricles. So what we call it the atrioventricular valves. We have two valves, the mitral valve that connect the left atrium to the left ventricle, and the tricuspid valve that connect the right atrium to the right ventricle. So the lub-dub component come from the closure, but because the opening of the heart valve is usually silent, but the closure usually generates the sound. And in addition to the outlet, so the dub component is usually by the outlet valves. What are the valves that are caused by the outlet valve? The aortic and pulmonic valves. So closure of the aortic and pulmonic valve will produce the dub sound. So it is better like thud-like sound, while the first sound is usually lub, it is intensity slightly higher. Okay, so this is the basic sounds that come from the heart, the lub-dub sound by the closure of the valve. So first of all, we have to come to the first heart sound, which is we call it is usually abbreviated as S1. So when you describe your clinical findings in the auscultation of the heart, you could mention the S1. It is the standard abbreviation for the first heart sound. And you can mention, or you can say that S1 is normal, for example, S2 is loud, etc. So the valve that is producing, this is the, what we call, this is the tricuspid valve. It is called by 3 cusps, 3 leaflets, 3 papillary muscles, and chordae tendineae. So the closure of the of this valve will produce part of the first heart sound. And the mitral valve الصمام الثنائي نسميه أو التاجي. It has 2 leaflets and 2 papillary muscles and 2 chordae tendineae. So the closure of both valves will produce the first heart sound. So it is generated by the closing the atrioventricular valves. What are the atrioventricular? These are the mitral and tricuspid valves. And the vibrations associated with the tensioning of the chordae tendineae and the ventricular walls. So this is the sound, the basic mechanism that produces the first heart sound. And it is what is the best site to hear or auscultate the first heart sound? It is usually over the apical area, over the mitral area. So how you can locate the apex beat from the previous session? We have to locate the apex beat by the flat of your fingers, put it over the chest wall, and you should definition of the area of maximum impulse, the downward and outward area. For example, in the fifth intercostal space, in the just medial or just lateral to the midclavicular line. This is what we call the mitral area. So it is not always in the fifth intercostal, sometimes in the sixth or sometimes in the fourth. It depends on the volume, it depends on the size of the heart. So it is changeable, not always in the fifth, maybe in the sixth, maybe in the fourth, or into the midclavicular line, lateral to the midclavicular line. It depends on the heart size. So S1 is usually best here in the heart apex over the mitral area. So this is for the first heart sound. On the other hand, the second heart sound is abbreviated as S2. The cardiac vibrations associated with the closure of the aortic, this is the aortic, and this is the pulmonic valve, which are the tri-leaflet valves, as you see, students, the tri-leaflet valves of the pulmonic, and so they consist of three cusps. Closure of these cups will produce the second heart sound, and it is usually based here at the base of the heart. So it is just lateral to the edge of the sternum in the second intercostal space. So this is the average, the dimension of the, like a fist of your hand. This is the average size of the heart overlying the, just behind the sternum, around length around 4 3/4 inch, and its width about 3.5 inch. So 8 centimeter by 12 centimeter. This is the usual size of an average adult heart. What about the auscultatory area? As I mentioned, that the mitral area is usually located in the fifth intercostal space in the midclavicular in a normal person, but there are some exceptions. For example, in a patient with dilated heart or an athlete heart, the heart may go bigger, so it may be here, maybe it's still palpated in the sixth intercostal space, just lateral to the midclavicular. Enormously dilated, so the apex will be still palpable at the anterior clavicular line, not mid, and maybe so dilated, so it can be still palpated in the sixth intercostal space here. So how you can decide the mitral auscultatory area? First of all, you have to decide the apical area. So the apical area, it will correspond to the mitral area for auscultation. So the mitral area is an auscultatory area. It depends on your localization of the apex beat. So please, no, don't put your stethoscope over the fifth intercostal space directly unless you palpate the apex beat and define it's the point of maximum impulse. This will correspond to the mitral area. So it is the only auscultatory area that is variable. يعني احنا عادة نسوي auscultation, the mitral area, it depends on your auscultation. While on the other hand, the tricuspid area, which is just lateral to the left sternal edge, it is usually constant in position, in addition to the pulmonic and aortic area. So these are fixed points, except for the mitral auscultatory area. Clear, students? I hope that this is very important, fundamental in the cardiac auscultation. So all the if you see a stem like this, all the auscultatory areas are fixed except the mitral area. It is true, because the mitral area depends on the position of the apex, which is variable from person to person. Though there are, for example, patients with heart failure, it will usually be dilated, so it's pushed downward and outward. Clear, students?
عفوا دكتور، بس السلايدات ما يتحرك، يعني ثابتة بس على أول سلايد اللي هي بارت كاردياك اكزامينيشن.
Okay, I will reshare again it. So it's now okay?
اوكي تمام دكتور، تمام.
So where is your last slide that is it is not keep moving? This is the slide, the first heart sound or the second heart sound? يا آخر سلايد شفتوه بعد ما تحرك؟
دكتور
الأول أو
هو من
الثاني؟
البداية متحركة، من البداية متحركة.
من البداية؟ Okay. So I'm going to briefly, these are the basic questions for our lecture. Where is the heart located in the chest? What are the systole and diastole? How do electrical impulses stimulate the heart muscle to contract? Name the pericardial sites recommended for auscultation. Which sound frequency transmitted by the bell of the stethoscope and the diaphragm of the stethoscope. Okay. Heart sounds, from the physiological point of view, it is produced by the vibrations of the heart walls, valves, in addition to the turbulent. The basic mechanism of heart sound consists of two basic: the vibration of the valves and the heart walls, in addition to the turbulence of the blood flow. And the ventricles are usually compliant in response to the pressure and volume, and this will decide the intensity and the character of any heart sound or murmur. The heart sounds, the basic mnemonic for heart sound, or the basic abbreviation, which we call it lub-dub sound. Lub-dub, the lub correspond to the first heart sound, and the dub component correspond to the second heart sound. How the heart sound is produced? The first heart sound is usually produced by the closure of the trileaflet tricuspid and the bileaflet mitral valve. So closure of these two valves will produce the first heart sound. When usually, I am asking a question to you, I have a question to you, when the atrioventricular valves closed in the cardiac cycle? When the atrioventricular valves closed during cardiac cycle?
During systole?
Yes, very good. During systole. So early in the systole, both mitral and tricuspid will be closed in order to prevent the blood going back to the atria. So these valves are usually closed early in the systole, so it will produce the first heart sound. The best auscultatory site for first heart sound are usually the apical site. This is the apical area, the point of maximum impulse. So you have to palpate the apical area first, decide where it is in its location, in which intercostal space, and its vertical plane, whether it is in the midclavicular line, in the anterior axillary line, in order to best hear the first heart sound. واضح طلاب لحد الآن? For the first heart sound, so it is produced by closure of two valves, the mitral and tricuspid. What about the second heart sound? It is usually produced by the closure of the aortic and pulmonic valve. Closure of the aortic and pulmonic valve. And it is usually best here at the basis of the heart. And what is closed during which time of the cardiac cycle?
Diastole.
So early in diastole, you should mention it. Early in diastole, just early in diastole, so after disappearance of the carotid pulse, you will hear the second heart sound. So the base of the heart, we mean the base of the heart by this, the pulmonic and the aortic component, which are usually in the second intercostal space. So this is the angle of Louis. This is the second rib. Below it, the second intercostal space. So on the left side, we have it, the pulmonic area, and on the right side, we have the aortic area. So the second heart sound best here over these two sides. The second heart sound, from the clinical point of view, will be subdivided into, you have two components of the second heart sound, while it is not so important in the mitral area for the first heart sound. So as far as the second heart sound is produced by the closure of the pulmonic and the aortic component, the second heart sound will be subdivided into P2 and A2. 2 stand for the second heart sound, P2 stand for the pulmonic valve, and A2 stand for the aortic valve. So closure of the aortic and pulmonic valve will produce two sounds corresponding to the second heart sound. So
العفو دكتور.
yes.
بس بالنسبة للسلايدات هسه احنا حاليا واقفين على سلايد 21 يعني مرة واحدة تحرك بعد ما تحرك وراها.
Sorry for this glitch. Okay, I'm going to share all screen. Okay. But yeah, which slide can you show me the picture?
سلايد 21 وبقى على سلايد 21 يعني.
Okay. Thank you for your notification. I'm going to stop presentation. So this is the slide. I'm sharing my screen now. Okay, it's okay.
ايه دكتور تمام.
Now هسه السلايد يتحرك.
ايه دكتور.
Okay, so I reached the slide for the second heart sound. Yep. So please let me know if the slides are not kicking off during my presentation. So the second heart sound, I told you that is produced by the closure of the pulmonic and the aortic valve. The tri-leaf, these are tri-leaflet valves. So when they are closed, they produce the second heart sound. And from the clinical point of view, to diagnose different pathological diseases of the heart, the second heart sound are subdivided into pulmonic component and the aortic component, and are abbreviated as P2 and A2. P stand for pulmonic, 2 stand for the second heart sound, while the aortic component of the second heart abbreviated as A2. A stand for the aortic area, 2 stand for the second heart sound. And so it makes sense that the pulmonic valve, the pulmonic sound are best heard are in the left in the pulmonic area, while the aortic or the A2 sound are best heard are the second heart sound, are the second intercostal space. And how you can know that this is the pulmonic area or the aortic area, clearly can be from, you can swap your finger from the suprasternal notch till the angle of Louis. From the angle of Louis, you can palpate the second ribs. This is from the angle of Louis, you can palpate the second ribs. Just below it, the second intercostal space, and is where the pulmonic area is located, and on the right side where the aortic area is located. So this is the how you can auscultate both the pulmonic second heart sound and the aortic second heart. While for the first heart sound, it is not clinically relevant to divide the first heart sound into S1 and S2. While for the second heart sound, it is important to differentiate between these two sounds. For the auscultatory areas, they are usually fixed, except for the mitral area, because its variables depends on the position of the apex. شباب واضحة لحد الآن؟ Where the mechanism of first heart sound, second heart sound, and the auscultatory areas, and how you can localize the auscultatory area. شباب الصورة واضحة هسه بالنسبة لكم for the sharing؟
واضحة دكتور.
زين. I'm going to ask some question. شوف والله. إيناس. Inas, could you hear me, please? Okay. مؤمل علي.
نعم.
So please, could you tell me where is the tricuspid area? Where it is located? The tricuspid area during auscultation of the chest. Yes, tricuspid area.
At the apex.
At the apex. Okay. Muhammad Amin. Thank you, مؤمل. محمد أمين أو أيمن العفو. محمد أيمن. صالح. Could you hear me, محمد? محمد أيمن. Okay, نادين حسين. نادين حسين. محمد علي محمود. محمد. أنفال عمر. طلاب صوتي واضح؟
نعم دكتور واضح صوتك.
شو طلاب مدري. أنفال عمر. أنفال, do you hear me?
نعم دكتور.
So I'm calling you. So please, you should answer immediately. Please, where you can localize the tricuspid area in the chest. Would you tell me the anatomy in which intercostal space? Tricuspid area.
Second intercostal space?
No. So I'm going to refresh your informations. This is the scheme for the auscultatory areas. M stands for what?
mitral.
The mitral area, the mitral auscultatory area. So when I palpate the mitral area and localize the apex of the heart, it usually correspond to the mitral area. I'm going to auscultate the first heart sound here. Okay. T stands for أنفال شنو؟ T أنفال stand for what?
نعم دكتور. mitral area.
T.
sound.
ليش سموها T العادة؟ الأم mitral area.
التراي. لا التراي.
إيه يعني from the abbreviations you can conclude your auscultatory area. So T stands for tricuspid area. It is usually where it is anatomically located in which intercostal space?
6 or 4?
No, it is a constant. It is usually in the fifth intercostal space. Fifth intercostal space, just lateral to the sternal edge. Just lateral to the sternal edge. واضح؟ This is the tricuspid area. Okay, thank you, أنفال. هبة الله. هبة. Okay, Abbas, Bilal.
نعم دكتور.
Please, could you tell me what is this? Is the picture showing the P? What does this stand for?
Pulmonary area.
Yes, the pulmonic area, and it is located in
the second intercostal space.
Yes, in the left. Yes, on the left side, in the left second intercostal space. So we are with Zainab Abdul Sattar.
نعم دكتور.
And lastly, the A in this
the aortic area
stand for the aortic area, and it is usually anatomically on the surface of the chest wall. It is located where?
in the second intercostal space on the left side.
So these are this is very important to you in your stage to able to know the auscultatory areas. I'm going to rapidly summarize. M stands for the mitral area. It is located where the apex beat is located. So it variables. It is usually located in the fifth intercostal space, just in the mid-clavicular line. But it is variable, depends on the position of the apex beat. While the tricuspid area, it is just lateral to the left sternal edge in the fifth intercostal space. The pulmonic area is located in the left second intercostal space, while the aortic area is located on the right second intercostal space. واضح طلاب هنا لحد الآن for the auscultatory area?
لا دكتور.
The second principle or the fundamental in the auscultation is the first heart sound is usually best auscultated where? In the mitral and in the tricuspid area, but it is usually in the mitral area. In order to know if there is any abnormality in the first heart sound, you have to auscultate in the mitral area. While if you would like to know if there is any abnormality, or if you'd like to hear the second heart sound loudly, it is usually best auscultated at the base of the heart. What we call the base of the heart. The heart تقريبا يعني صاير هو بالعكس upside down. So this is the base of the heart, and this is the head of the heart. The base of the heart, what we call, this is the base side to auscultate for the second heart sound. This is where, if you can hear the pulmonic component, you should auscultate in the pulmonic area, and if you'd like to auscultate the aortic area, you should auscultate in this position. So this area for first heart sound, and this area for second heart sound. يعني أنت متخلي السماعة بالpulmonic والaortic area. Forget the first heart sound. You should neglect the first. You should concentrate on the second heart sound, because this area is the best area to auscultate the second heart sound. And similarly, in the mitral area, when you put your stethoscope on the mitral area, you should focus on the first heart sound. For example, its intensity, whether it is normal, it is loud, diminished, or absent, and whether there are any other abnormalities in the first heart sound. واضح؟ نفس الشيء بالنسبة للbase of the heart. When I want to hear the pulmonic component or the aortic component, you should focus on this area in respect to heart sound. هسه بالنسبة شنو طلاب عرفنا ال first heart sound. This is for the first heart sound. قلنا closure of the mitral and the tricuspid valve. It is not so clinically important to separate إنه نسوي مثلا ال S1 ب مثلا M1 و T1 مثل ال P2 وال A2 for the second heart sound. It is not clinically relevant, and is generated by the closure of the mitral and tricuspid valve. Keep in your mind that the mitral valve closure precedes the closure of the tricuspid valve by a few milliseconds. So, but it is clinically, we can hear one heart sound for the first heart sound. يعني احنا بنخلي السماعة for the first heart sound, you can only hear one click, يعني one lub. ما راح نسمع two component. On the contrary, the second heart sound, it is usually have some splitting. So when you auscultate in the pulmonic aortic area, especially at the end of inspiration, you can hear two clicks for the pulmonic and second heart sound, because it is usually widened during inspiration. So the second heart sound, in summary, produced by the closure of the aortic and pulmonic valve. Since the depolarization of the and repolarization of the left ventricle precede the right ventricle, so the aortic valve slightly precedes the closure of the pulmonic valve. What about the extra heart sound? So you have in the auscultation in the mitral area or in the pulmonic area, you have to hear the normal sound, whether it is normal, loud, quiet, or absent. In addition, you have sometimes you can hear an extra, which we call it extra heart sound. يعني it is not normally present, but sometimes we can hear what we call it extra heart sound. So the normal heart sound are S1 and S2. Sometimes we can hear an extra heart sound, we call it extra heart sound. It may be normal and it may be pathological. The extra heart sound, the first extra heart sound is the S3. It has sometimes physiological and sometimes pathological. The third heart sound is considered normal in individuals younger than the age of 20. So if you could hear an third heart sound in a person younger than the age of 20, so it may be regarded as physiological, especially in athlete young adults also. In addition to the age, and sometimes you can above this age, if we found an athlete. What is the mechanism? This is a very important question. What is the mechanism of the third heart sound? S3 stands for, you know, third heart sound. What is the mechanism behind that? It is usually occur during rapid and passive. This is very important. Two principal mechanism that produce the second heart sound. It is produced by rapid. So rapid flow from the atria to the ventricles, rapid and passive. So it occurs, يعني شو تتوقعون? This is occur in systole or diastole, first of all. انتبهوا على العبارة. It is usually occur during rapid and passive. It's very good. So it is usually occur in diastole. The second question, it is when it occurs, early in diastole or late in diastole. So rapid, passive. Rapid, passive. Yes, it is early because it is passive filling. So once the aortoventricular valves opens, there will be rapid flow. This rapid flow will produce this sound. So it is very important. It is occurs in early diastole, and the mechanism of which, it is a common question in the exam, it occurs during rapid and passive. When the late in systole, late in diastole, there will be contraction of the atrium, so it is not going to produce this sound. Whereas the opening of the atrium, this usually happen early in diastole, so it will produce this sound. A very important note, it is abnormal in patients older than the age of 40. So if you hear the sound in a patient older than the age of 40, even an athlete, you should regard it as abnormal until proven otherwise. واضح طلاب? You should regard it abnormal at or above the age of 40. So where you can hear the best auscultatory area for the second or for the third heart sound, it is usually also in the mitral area. If there is abnormality in the left ventricle, so rapid flow from the left atrium to the left ventricle will produce this sound. For example, in pathological conditions, in a patient with heart failure, and volume overload, so there will be rapid flowing from the left atrium to the left ventricle. And since the left ventricle, the apex correspond to the left ventricle, so it is best here in the mitral area, mitral auscultatory area. واضح طلاب? So the mitral area, it is usually variable dependent on the position of the apex beat. So, but sometimes in other conditions, what we call, this is then left ventricular third heart sound. But there are diseases in the right ventricle. For example, in a patient with respiratory disease, the right ventricle dilated, what we call it core pulmonea, there will be dilatation of the right ventricle, but the left ventricle is normal. Here we can hear also S3 come from the right ventricle, what we call it right ventricular gallop. This is the left ventricular S3 or the right ventricular S3. This is best here not in the mitral area because the right ventricle, it is not located here. It is usually located here near the tricuspid area. So S3 for the left ventricle, it is usually best here where in the mitral area, while the S3 come from the right ventricle best here in the tricuspid area because this area is in close approximation with the right ventricle.
دكتور
Yes.
عفوا احنا قلنا انه الفيرست ساوند راح اسمعه هنا بالمايترال والتراكسبيد اريا والثيرد هم بالمايترال. شلون اعتبر؟
You will hear two sounds. Yes, you will hear first heart sound, second heart sound, and then just after the second heart sound, you will hear a sound between S1 and S2. After S2, especially after S2, you will hear an additional sound. Just after S2. يعني شنو? After the disappearance of pulse. After the disappearance of pulse. So how you can differentiate this is S3 or S1? Clinically, by just palpation of the, you can palpate the carotid. The S1 is usually corresponding with the pulse, while S3 is usually correspond after S2, after disappearance of pulse. واضح? So S1, clinically, how you can know this is the first heart sound or second heart sound. So timing here is important. You should palpate the carotid and then put your stethoscope. If you hear the sound that come with the pulse, this is systolic, which correspond to the first heart sound, while disappearance of pulse and you can hear a sound, this is the second heart sound. So after diastole, you will hear two sounds, the second heart sound and the extra heart sound, which we call it the S3. Especially it is usually very close to the second heart sound, yani after disappearance of pulse. Thank you for the question. So please, do you have any other questions? Here are some knowledge about the S3, which is usually here, best near the apex of the heart, over the mitral area. This is for, this is for the left ventricular S3, while the right ventricular S3 is usually best here over the tricuspid area. And its pitch is low, so it is low heart sound, intensity is low, and the pitch is low. It is different from the second or third sound because it is usually has higher pitch. And we know that the stethoscopes have two components, the diaphragm and the bell. And so if you have a look on your stethoscope, it consists of two components, the bell, the smaller side, and the diaphragm, it has a wider space. So for extra heart sound, it is best here with the bell of the stethoscope because its pitch is low. So this component is usually going to filter and augment this low pitch sound. And it has a dull thud-like quality. And for your question, its timing is closely related to the second heart sound after disappearance of the pulse. So it is just early in diastole, after disappearance of the carotid pulse and related to the second heart sound. So this is for S3. What are the causes of each heart sound? You have to know its causes, whether it is physiological or pathological. So from its mechanism, it is caused by rapid passive ventricular filling. So it is caused by area of increased volume. What are the physiological conditions that are going to increase the volume? The blood volume. يعني تخيل انتم شو مثلا عندنا مثل jug of water, and its volume has high volume, and we can evacuate it rapidly to another. So as far as the volume of this jug is higher, the sound will be more augmented. So what are the mechanisms, what are the causes of physiological causes that produce third heart sound, other than age, young age, and athlete?
Doctor, ventricular failure?
Normal. What about normal causes?
Doctor, during pregnancy?
Yes, during pregnancy, very good. We have third heart sound, we have normal or physiological causes and pathological causes. So pregnancy, because of an increased blood volume and increase in the plasma volume. So you may hear it in pregnant, young, or any pregnant lady who have no normal heart, not abnormal heart. So it may be bad.
Ventricular systolic failure?
This is pathological cause. I am asking about physiological causes. Yes, so number one, during exercise, maybe rapid external exercise, you may hear S3 because of rapid hyperdynamic circulation. It may cause rapid filling of the left ventricle. During pregnancy, during fever also produce hyperdynamic circulation. There will be rapid passive ventricular filling. So here are some causes of the third heart sound. What about the pathological causes? Yes, you mentioned already the ventricular failure because of fluid volume overload, dilated ventricle. You may hear an S3. And other causes, you can return to your textbook of clinical examination, Mark Cloud. There are some causes for S3. The S1, S2, and S3 sequence is referred to what we call it ventricular gallop or gallop rhythm, because it is like the gallop of the horse, the gallop rhythm, and it is heard over the same location and have the same timing in relation to S2, or what we call it, there are physiological and pathological causes. The difference between the two are related to the patient age, clinical condition of birth. So how you can know that this, how you can differentiate between the physiological or abnormal S3, it depends on the patient age. Above the age of 40, if you hear a gallop rhythm, this is unlikely to be normal. Clinical condition, if the patient is a known case of heart failure and you hear S3, even if it's the patient's age below 40, this is likely abnormal. because the patient already has heart failure. Okay, or it depends on both the age and the clinical condition. So here يعني مو يجي مريض heart failure عنده اقول لك what are the causes? This is physiological or pathological? يقول لي physiological because his age below 40. No, because it depends on the clinical condition. So you have to put it in the context of the patient, whether the patient has heart failure or مثلا mitral regurgitation or mitral incompetence, has already a valvular abnormality, and in addition to the patient's age. يعني مو patient age 50 and you will likely to call this is physiological. No. So the patient age and clinical condition are very important to put in mind when you interpret the third heart sound. واضح طلاب؟ هسه بالنسبة لل third heart sound المهم اللي تعرفون به لازم mechanism of third heart sound, the best site to auscultate, and know the some causes for the third heart sound.
تمام دكتور.
Okay, so I'm going to ask him. محمد أيمن. محمد الظاهر مو موجود أصلا. بدور حسين.
محمد علي دكتور.
بدور. محمد أيمن العفو. بدور حسين جاسم.
نعم دكتور.
So please, could you explain the mechanism of third heart sound?
Rapid passive ventricular filling.
Okay, very good. So rapid and شنو? Passive. So without atrial contractions. Rapid and passive left ventricular filling. Rapid and passive left ventricular filling. So تبارك شكرا زينب أو شكرا بدور العفو. تبارك سلام.
نعم دكتور. نعم دكتور.
So when it is when this occurs, the rapid ventricular in systole or diastole?
In diastole. Early in diastole.
Early or yes, it is this third heart sound usually happened early in diastole. Okay, شكرا تبارك. زيد سعيد. زيد سعيد. زيد. اوكي زيد موجود ويانا. عباس بلال.
نعم دكتور.
Okay, what is the best site to auscultate for the left ventricular third heart sound?
دكتور left ventricle الترايكاسبيد العفو المايترال.
Mitral, yes. So please. So for the everything related to the left side of the heart, it is usually best here in the mitral area. It's usually best here in the mitral area. Okay, thank you. So we're going to move to the fourth heart sound. So please, could you see this slide? Fourth heart sound.
Yes, doctor.
So the fourth heart sound, it is by the mechanism of when it is related to the cardiac cycle. By the end of diastole, this is very important. By the end of diastole, the ventricles are nearly full. Atrial contractions. So by the end of the diastole, as a result of passive filling of the opening of the mitral and tricuspid valve, by the end of diastole, the ventricles already loaded with the blood from where? From the atria. So by the end of diastole, the ventricles are nearly full. Here there will be atrial contractions, so it is not passive. Atrial contraction further stretches and fills the ventricles. So this is the basic mechanism why the fourth heart sound sometimes appear. So it is caused by forceful atrial contractions against the ventricles. The vibration is caused by this filling and stretching in the late diastole. So it's very important. Filling, stretching, and forceful atrial contractions late in diastole will generate this heart sound. Keep in your mind that this is very important. It isn't produced in conditions in which atrial systole doesn't occur, such as atrial fibrillation. Why? Do you know why? In a patient with atrial fibrillation, you will not hear a fourth heart sound.
During atrial fibrillation, ماكو contraction بالاتريا.
Oh, very good. Why? Because why there will be not contraction in the atria?
والفيبريليشن يكون يعني سريع
So there will
جدا
be
ما
no,
يصير
yes,
في
yes, there will be
contraction.
yes, there is chaotic electricity in the both atria, and there will be no proper forceful contraction of the atrium. So there will be like this, just atrial contracting is very not forceful, not organized, but chaotic, and not forceful. So the fourth heart sound is usually, is always absent in the presence of atrial fibrillation. Please don't say S4 in the presence of atrial fibrillation. So the best site is usually correspond to the mitral area. So S4 is usually located near the heart apex over the mitral area. So the S3 and S4, both of them can be auscultated in the mitral area. But it needs a very important listening skills in relation to the cardiac cycle. S3 is usually just after the second heart sound, early in diastole, while the fourth heart sound is usually here late in diastole, in a close approximation to the first heart sound. Because at the end of diastole, after that, there will be first heart sound. So the S4 is in a close approximation to the S1, while the S3 is close approximation with the S2. شباب واضح هسه بالنسبة للfourth heart sound, its mechanism of action, and the best site to auscultate for the S4. Keep in your mind, S4 is usually is almost pathological in comparison to the third heart sound. So whenever you hear an S4, it is usually pathological. What are the causes of fourth heart sound? Usually the fourth heart sound as a result of forceful contraction that against some stiffening. So normal contraction of the atrium will not produce this heart sound. But as far as the ventricle become hypertrophied and stiff, this will produce this fourth heart sound. For example, in patient with long-standing atrial hypertension, and patient with, for example, left ventricular hypertrophy as a result from hypertension or disease, other diseases that will produce this left ventricle. So the ventricle will be enormously hypertrophied and become stiff. So atrial contraction, which could cause vibration, and active filling of the left ventricle will produce this fourth heart sound. Other causes, for example, in patient with ischemic heart disease.
Ischemia.
Yes, ischemic heart disease sometimes will produce this. Why? Because ischemia will cause stiffening of the wall of the left ventricle. So it can be patient presented with angina or left myocardial infarction. You can hear a second or an extra heart sound, what we call it S4. And added in a patient MI, and you hear a sound in diastole, and you can't conclude because S4 will not produce by the same causes of S3. So if you hear an extra heart sound in patient with MI, so this is likely due to S4. And a patient with heart failure, if you hear an S3, this is likely an extra heart sound after diastole. This is likely due to a third heart sound rather than fourth heart sound. But here it needs a very good listening skills and its relation, whether it is close to the S2 or close to the S1. And keep in mind, in patient with tachycardia, so there will be shortening of the diastolic time. So it would be very difficult for the junior doctors to know whether this extra heart sound is the result of fourth heart sound or S3. Why? Because during tachycardia, the diastolic time will be shortened. So the S3 and S4 become so close to the second heart sound. So you could not appreciate whether this extra heart sound is S3 or S4. This is some caveat about the auscultations in your practice. But in patient with bradycardia, so there will be wide diastole time, so you can really easily appreciate this extra heart sound, whether it is due to S3 or S4. So during auscultation, you have to know that, just to recap, the S1 and the S2, then listen to the extra heart sound in the mitral area, especially for the S3 or S4. Then you have to know if there are any other sounds like snaps or clicks. An opening snap, what we call this term, an opening snap, is commonly heard in the mitral area. How? What is the mechanism of the opening snap? It results from sudden opening of a stenosis valve. For example, patient with aortic stenosis, the valve is already stiffened. So during systole, when the blood flow, the pressure in the left ventricle exceeds the pressure in the aortic valve, so the valve will be open. And as a result of stemming of this valve, once the valve is open, so it is usually heard after the opening of the valve. Okay, the common example of the opening snap is the opening of the stenosed mitral valve. So when it usually occurs after S2. So opening snap is usually here in the mitral area. When it's going to open the mitral valve, it is usually opened in diastole. So the atrioventricular valves normally open during diastole. So because the valve is stenosed and stiffened, so once it is opened, it will produce what we call it a snap. So sudden opening of the valve will produce a snap. So it results from sudden opening of a stenoid valve and occurs early in diastole. So it is its time is similar to S3. So early in diastole, just after the S2. So this is the first heart sound. This is the systole. This is the second heart sound, and this is after that you can hear the opening snap, and then later on, and so on and so forth, S1, S2, S1, S2. So the basic mechanisms of the opening snap result from sudden opening of stenosed thickened valve leaflet, the timing early in diastole, and the base site here with the diaphragm. With the diaphragm and the apex, okay? This is the base side for the side to auscultate. So here in the diaphragm, in the mitral area. Another sound is the click, ejection click. It is high-pitched sound, based here with the diaphragm also. The difference between the click and snap, the snap usually occurs in the diastole, while the click usually occurs in systole. So after first heart sound, after closure of the atrioventricular valves and the systole, the pressure in the ventricles exceed the pressure in the aorta, and there will be sudden opening of the aortic and the pulmonic valve. So they occur early in systole, while here occur early in diastole. Here occur early in systole. Just after that, so you'll hear this lub, then tick, then dub. So you'll hear a tick just after the first heart sound. Sorry. So it is you will hear a tick sound or a click sound just after the first heart sound. So it corresponds with the pulse. And the principal causes of the ejection clicks are the pulmonic and aortic stenosis. So here the basic mechanism, it is usually occurs as a result of opening of stenosed valve. وهنا ممكن تستنتجون what are the causes of opening snap early in diastole. So could you conclude the cause of opening snap? The ejection click usually occurred as a result of pulmonic and aortic stenosis just after the first heart sound, while the snap usually occurs early in diastole from sudden opening of stenosed valve. So what are the valves involved in the originating from? It results from stenosis of the mitral,
tricuspid.
Aortic
stenosis of the stenosis, sudden opening during diastole. The aortic and pulmonic valve is closed, right? During diastole, the pulmonic and the aortic valves are closed, while the atrioventricular valves, and the mitral and tricuspid will be open. During diastole, خلوا بالكم طلاب, during diastole, the aortic and pulmonic valves are usually closed. What valves are open now? The mitral and the tricuspid valve. So any stenosis in these valves, the mitral and tricuspid, will produce this sound, what we call it snap. So just imagine after diastole, the mitral and the tricuspid valve are open. If these valves are stenosed, will produce this sound. شباب واضح بالنسبة للسناب والكليك؟ Clicks in systole, snaps in diastole, clicks just after the first heart sound, while snaps occur after the second heart sound. clicks usually caused by the pulmonic and the, because the pulmonic and aortic valves are open during systole. So stenosis of these valves will produce the click during systole. And this is true for mitral and tricuspid valve because they open during diastole. So any stenosis of these valves will produce a snap during diastole. شباب شلون هالمعلومات لحد الآن صعبة ولا سهلة؟ So just imagine the cardiac cycle. During systole, which valves open and which valve close. During diastole, which valves open, which valve close. From knowing this normal physiology, you can know whether the patient has a click or snap. So till now, you have any question?
دكتور بس الاصوات التي 3 والتي 4 الفرق بيناتها بالصوت لو بس بالتايمينج.
This is a good question. Thank you, Muammar. The best side to appreciate whether the patient has ST3 or ST4 is from timing. Timing is very important because ST3 and S4 usually have the same pitch. Both of them are low pitch. يعني intensity مالتها low اثنيناتهم. The pitch مالتهم also low. So knowing the character of sound is not going to help you in differentiating S3 versus S4. But timing is very important. Timing is very important. S3 is close to the second heart sound, while S4 is close to the first heart sound. Thank you, Muammar. بينما يعني بالنسبة للclicks and snaps is very important differentiation because the clicks happen systole while snaps happen in diastole. شباب عندكم سؤال؟
عفوا دكتور. نعم دكتور.
نعم.
دكتور يعني هسه احنا افتهمنا كل خطوة وكل شغلة شنو معناها. نعم. اي بس يعني انه كسيناريو كله يعني مثلا من يجينا البيشنت شلون حيكون السيكونس؟ شلون حيكون التسلسل؟
I will summarize the sequence at the end of my lecture. Good question, Inas. But I put it in the end. Just in the context of this slide, I need you to know the basic mechanism of each sound. What is the basic mechanism of first heart sound, the second heart sound, the third, the fourth, the extra sound, and the added sound like clicks and snaps. So if you hear this sound, you can conclude from its physiology. So if we have no questions.
عفوا دكتور.
Yes.
دكتور بالاكسترا ساوند والادد ساوند هم يحتاج تريتمنت؟
These are signs which underlie disease process. So it depends on the disease process, definitely. If it is physiological, it is not needed for treatment. But it's pathological, we need to treat the underlying condition. So for the heart sound to be treated. So it is not a therapeutic point. It is not a therapeutic target, but it is a sign of underlying disease. And if you feel a hypertensive patient and you feel a fourth heart sound, this indicates that the patient has long-standing hypertension, left ventricular hypertrophy, so it needs to control his, hypertension. Thank you, Muhammad. شباب واضحة الأمور عندكم؟ Okay, as far as you have no questions, so I'll move to the next added sound. The last added sound is the pericardial rub, what you call it, friction rib. Why it is called this friction? Because it is a coarse scratching sound, often with systolic and diastolic components. What is the mechanism behind this mechanism? It is usually a result from scratching of the pericardial surfaces in a disease process. For example, if there is an inflammation of the pericardium, the sheath that cover the heart, you already know that the heart is covered by what we call the pericardium. It is a composed of elastic and connective tissue fibers. So if both the visceral and the parietal surface or the pericardium scratch over each other as a result of inflammation, it is usually result from this sound, what we call it pericardial rub. So this is the basic mechanism. It is usually result from inflammation of the pericardial sac. Inflammation of the pericardial sac. واضح شباب? This is the basic mechanism. For example, a patient who have viral pericarditis. مريض عنده viral pericarditis. It usually started with the flu symptoms, cough, fever, followed by chest pain. When you are going to auscultate, يعني suppose you face a patient who is 20-year-old male presented with the flu symptoms followed by severe chest pain. So one of the differential diagnoses of chest pain in young age group is after flu symptoms is pericardial friction rub. So how you can diagnose this condition? It is usually by asking proper history followed by examination of the pericardium and auscultation. It is best here using the diaphragm. Why? Because it is high frequency, high pitched sound. While the low frequencies, low pitched sound is usually best heard why? With the bell. With the patient holding their breath in expiration in order to bring the pericardium near the surface of the sternum, just below the surface of the sternum. لذلك المريض شو نقول؟ أخذ نفس، فرغ صدرك من الهواء, then hold your breath at the end of expiration. What is the site, best site to hear the pericardial friction? It may be audible over any part of the pericardium. يعني ممكن تخلي بالمايترال تسمع بالبريكارد, بالترايكاسبيد, بالبulmonic, بالاortic. So it is usually have no, may be audible over any part of the pericardium, varying in intensity over time and with the position of the patient. يعني ممكن المريض أديره على اليسرى أسمع أقوى، أديره على اليمين يختلف شوية. So it varies with intensity. And over time also يعني شنو over time؟ يعني مثلا اليوم فحصه لقيت intensity مالته عالية. مثلا باكر جيت لقيت intensity أقل. أو هسه جيت شفته there is pericardial friction rub. بعدين قلت لك اكو مريض مثلا شفتك بالردها قلت لك اكو مريض have a good sign please auscultate the pericardium. يعني you get and you auscultate the patient, you come to the patient, auscultate his pericardium and you didn't hear anything. Why? Because it is variable intensity and variable with the time. So it is not always position. It depends on the magnitude of the inflammation and the presence, whether there is any fluid, lubricating fluid between the areas of pericardium. ممكن المريض ورا فترة راح يصير fluid inside the pericardium, so the friction will be absent. لذلك لما تيجي تخلي سماعك وش ما راح تسمع. واضح؟ So it varies, depends on the time, intensity, position of the patient. What is the best site? Usually the best site to elicit the pericardial friction rub, we have two sides, either in the left lateral position and ask the patient to roll on the left side and hold his breath at the end of expiration, or ask the patient to lean forward over the tricuspid area and in the left lower sternal edge, lean forward, hold his breath at the end of expiration. So this is the two preferred site to elicit pericardial friction rub, either in the left lateral at the end of expiration in the mitral area, or ask the patient to lean forward and put your stethoscope in the tricuspid area and ask the patient to hold his breath at the end of expiration. This is for pericardial friction rub. It can be easily, once you hear the pericardial friction rub, usually you will not forget the sound because it has characteristic scratching sound. And يعني احنا عادة معظم الساوند in the cardiac cycle either systolic or diastolic. This is one of the exceptions. You will hear sound in both systole and diastole. And you have scratching sound, like scratch. يعني شلون الورقة تحكها بورقة ثانية. Have two components, systolic and diastolic. So scratching sounds, like putting two coarse papers over each other and scratch it one over the other. So it's very distinguished sound by its character. واضح شباب؟ So it has both systolic and diastolic component. The next topic in my lecture and the last topic is the murmurs. شباب شنو الأخبار؟ شلون المحاضرة؟
دكتور زين.
زينة. ناخذون بريك at 5 minutes in order just to refresh because the murmurs is a very important topic. I need to concentrate. But so far, if you have any question, عندكم سؤال شباب؟
لا دكتور.
دكتور واضحة المحاضرة.
We will continue or you will have a break. So شنو رأيكم؟
دكتور ناخذ بريك دقائق.
اوكي. شو تقولون الباقي؟ ناس تقول ناخذ بريك؟
اي دكتور
We'll have a break or not? Okay, we'll have a break. هسه 38 يعني تقريبا at 12:45 we will resume my lecture. Isn't it? Okay, so you can have a rest and then go back again to the lecture.